who spoke about the pathophysiology. So today I have decided to deal only with diagnosis and management, a little brush to the pathophysiology, but we won't spend more time into this. So this is me, and I've been introduced well, and thank you for that. And as we look at polycystic ovarian syndrome, it's one of the most common causes of infertility in women world over, frequently becomes manifest during adolescence, and primarily is characterized by ovulation dysfunction and hyperandrogenism. What is very important is the Indian continent, and especially the Asian women, have a huge, massive underlying issue associated with insulin resistance. And that is one of the reasons why probably the incidence of this PCOS world over, when we say 1 in 10 patients, I think it is much more and wider in India and in our country. So the diagnosis is usually clinical, but then there are also certain biochemical markers which one has to be well versed with, and therefore this variability has to be taken into. There'll be cutaneous symptoms of hyperandrogenism, hirsutism, moderate acne, menstrual irregularity is the commonest way in which women come to, especially when there are young teenagers. And then a Usg finding will suggest a polycystic ovary. Sometimes we need to interpret it correctly. And obesity and insulin resistance. Sometimes obesity is an overt or a sort of a thing which we can definitely see, but insulin resistance can be a hidden factor, and we require to investigate it for. And therefore, you will have various kinds of combinations, which will be typical classic polycystic ovarian syndrome. You can see in this cycles here, these wheels. There can be an ovulatory PCOS. There can be a PCOS with an ovarian hyperstimulation syndrome. There can be a non-hyperandrogenic phenotype. And then there would be somebody who would be just androgenic. And then there can be patients who have subfertility, who are at risk of developing endometrial hyperplasia and have menstrual dysfunction because probably they are suboptimally ovulating or are anovulatory. So therefore, this entire gamut, if we look at the imbalance of the LH to FSH ratio, which we usually try to look for through the laboratories, sometimes it has relevance. Not much relevance in an adolescent patient, but much more relevance in a patient who's undertaking treatment for fertility or pregnancy planning. There's a chronic insulin resistance. There is disturbance in the HPO axis. The adipocytes and the ovaries and the ovarian stroma are responding in a different way. And these have been identified to be having an underplay of a genetic mutation. There is a lot of epigenetic modification. And what is very important today, we have to understand that this epigenetic modification is bring about phenomenally by environmental abnormalities. There are many environmental bursters like pollutants, pollution, or certain food condiments which have been identified to be responsible for this dysregulation of the insulin, androgen degradation, the entire metabolism, making this woman at risk of not only short-term complications that we have to deal with as a gynecologist, but long-term complications as the woman goes on in age. Now, the past 25 years, internationally accepted diagnostic criteria have been developed based on various combinations of otherwise unexplained anovulation, polycystic ovary on a sonography, either one or both, and which are all encompassed actually by the Rotterdam consensus criteria. And we have always been talking about these criteria, where Rotterdam in 2003, primarily Androgen Axis Society, mentioned that it's basically an androgen axis and an ovarian dysfunction starting from there, while the Rotterdam then made it a little easy for us to identify women who have oligoanovulation, clinical and biochemical signs of hyperandrogenism, and polycystic ovaries on ultrasonography. And then, of course, we have to be warned about multicystic ovaries only on ultrasound, especially in an adolescent age group. And what is going to be that, I'm going to speak to you shortly. Now, so if you look at the summary, what we have today, in an adult phenotype, we find that there are actually identified 4 phenotypes in order of decreasing clinical severity of androgenism, insulin resistance, obesity, LH axis, which corresponds to decreasing specificity of the milder phenotype. So you have a phenotype A, classic PCOS, phenotype B, hyperandrogenic with anovulation, phenotype with ovulatory PCOS. The phenotype A would sometimes ovulate also, but there will be an ultrasonographic evidence of polycystic ovary. Phenotype C will have an ovulatory PCOS, ultrasonographic evidence of a polycystic ovary, and phenotype D will have evidence of oligo and ovulation. What we have to understand is ultrasonographic evidence of polycystic ovaries usually seen in all of them, and specification of phenotype is proposed in a workshop convened by NIH in 2012, and these are in order of decreasing clinical severity, and each set of diagnostic criteria requires exclusion of other causes of hyperandrogenism and ovulation. Now, why is this important? This is important because over a period of time, there are 2-3 types of experiences we get in our practice. Patients coming with a label chipped out on herself saying, "Doc, I am a PCOS." I have so many of them. "Doc, I have Pcos." That's the word that they use. And then they label themselves and get into that. Sometimes we find that there are so many other differentials which may be there, and she may not have PCOS. And there's one more thing which I want to identify, and a lot of thought is going over this, that probably obesity also influences the ovarian structure organically and functionally in such a way that there can be a PCOS-like picture, and that is something that we need to look into. Now, these criteria, which we discussed just now, cannot apply the same to the adolescents. Anovulatory cycles and associated menstrual irregularity are frequent in this adolescence, yet because it's still a building in making, under construction. The common signs of hyperandrogenism in adults are less reliable when applied to adolescents because hirsutism is in a developmental phase and acne vulgaris is common. Measurement of testosterone concentration in adolescence is problematic because serum concentrations rise during anovulatory cycles. There's paucity of reliable norms of these androgen levels in this age group, and extent to which adolescent hyperandrogenism predicts adult hyperandrogenism is unclear. And morphology of the polycystic ovary by the adult standard is very common because it's the ovary which is just trying to come of age, and that time it is a little enlarged in size, and therefore the same criteria that we speak in the Rotterdam criterion for sonography may not fit in here. And you must therefore understand that there is a distinct differentiation between a polycystic ovary on an ultrasound and a multicystic ovary, which is typical of the adolescent age group. So the international consensus diagnostic criteria for PCOS in adolescents is otherwise unexplained combination of abnormal uterine bleeding pattern, that is abnormal for age or gynecological age, persistent symptoms of 1 to 2 years, evidence of hyperandrogenism either through the laboratory reference levels with a testosterone elevation, moderate to severe hirsutism, and moderate to severe inflammatory acne vulgaris is an indication to test for hyperandrogenemia. And this is something which has been devised by the AAP and also endorsed by the European Society and the ACOG to accept as a diagnostic criteria for adolescents, because we have to be very careful when we offer them treatments. So whether, and this was what I was saying some time back, a PCOS phenotype exists in which obesity is accompanied by intrinsic ovarian hyperandrogenism in the absence of hirsutism or acne and anovulatory symptoms still remains to be determined. And we have a whole lot of such young girls coming, short in stature, fat in their width, do not have typical hyperandrogenism, but have everything similar to a Pcos. Now, this is some word which I use because of my patients very commonly. So it is multiple metabolic and endocrine abnormalities are associated with this, and these abnormalities have been associated with as much as 40% risk of pregnancy loss, and that is terrible. And many studies have suggested that weight loss and the use of insulin sensitizing agents reduce the rate of spontaneous loss in PCOS patients, although the latter investigations continue to be actively contested, and that's how we are going to look at these. Now, the typical clinical features would be hirsutism treatment, acne, menstrual irregularities, acanthosis nigricans, and obesity. And it's a good practice to look at the neck of the patient for the pigmentation on the body, and that can give you your clues. And PCOS in adolescents is usually recognized because of the symptoms of hyperandrogenic anovulation. 1/3 of the cases come to medical attention because of hirsutism, obesity-associated acanthosis, before menstrual abnormalities become apparent, and one half of patients are non-obese. And these are the true challengers in our practices. Please remember that there is a prevalence of non-alcoholic stereohepatitis, like the typical NASH-like appearance, and you can see fatty liver on ultrasound. And this is also seen increased in women in PCOS, And anxiety, panic attacks, and so many depressive kind of disorders are very commonly associated. And it should be a good clinical practice to inquire about this and assure women, because they are much bothered. There's a lot of things coming up in the media about PCOS. They read, they Google, and they come up with, a usual, very, very nutty kind of a mindset. So let's look at the Usg Pcos criteria. I think something happened to my image here, doesn't matter. According to the Rotterdam Consensus and the Androgen Axis and PCOS Society, ultrasound criteria consists of the presence of 12 or more follicles within the ovary with a diameter of 2 to 9 millimeters and or ovarian volume of 10 centimeter cube or greater. So this is something that we have to remember. Get into the habit of looking at the ovarian volume. Ovarian volume need not be taken from all the 3 sides, just the 2 sides matter, and that gives you a clue whether this is a PCOS ovary. Now, when we talk of hyperandrogenism, the various evaluations, especially in the androgenic group, in the adolescent group, we have to think of DHEAS and what its role. It's been found that it is mildly elevated in 30 to 40% of the PCOS, but if it is very much more, then it can be maybe because of an adrenal tumor, and this is a very rare entity, but we have to be aware of this particular things. And 17 OHP is usually found to be present during the follicular phase, is the time that you have to look at, and if it is found to be more than 4 nanograms per ml, then it is non-classical, and borderline is taken between 2 to 4 nanograms per ml. Actually, in practice, I usually do not practice any of these, because looking at the patient's clinical parameters itself, we can get into the know-how, and many a times if you help them through their lifestyle changes and how with an evidence, I'll tell you, then that would help. But then sometimes you would have patients who are coming to you with severe features suggestive of virilization, and we need to know, then should I also include a sonography of an adrenals? Now, primarily it is done to evaluate for rare tumors of these organs when these tests come abnormal, or when you're suspecting on your clinical examination where there is rapid progressive hirsutism, clitoromegaly, and menstrual abnormalities that fail to respond to the therapy that you're offering. So if you look at the criteria for diagnosis of PCOS, which was mentioned in 2006, hyperandrogenism with elevated serum androgen levels or biological expression of hyperandrogenism in the form of acne or hirsutism, ovarian dysfunction, and morphological abnormal PCOS like ovaries, and absence of other causes of anovulation. And we have to differentiate, because there can be thyroid disorders, hyperprolactinemia, and certain other adrenal abnormalities, which can also give rise to typical PCOS-like syndrome. So when the patient has come to you with these complaints, the questions that should also be asked in addition to this is, what is her lifestyle? What is her physical activity? Her diet recall, it's extremely important. Even if you ask her 2-3 times diet, what she takes, it gives you a clue as to what kind of diet she's taking, whether she's suffering from indigestion, constipation, dyspepsia, because that also gives us an insight into what actually is happening at the end of nutrition level. Because many a times this is what is happening, especially to our urban bound population, where they do not have access to good nutritive food, and they suffer from various things, and they're constantly trying to starve themselves, whether there is fatigability, whether they are exposed sexually, because that's also something we have to certainly ask, because is that going to be a problem? Many women, many young girls are popping in eye pills just at the top of the hat, and their over-the-counter medicines being consumed for various reasons, which you have to ask them, and whether they have mood issues and temperament issues. Now, there are certain pictures which I've put in here. Is sedentary behavior is something that you must definitely ask for. It refers to any waking activity characterized by an energy expenditure of less than 1.5 metabolic equivalents and a sitting or reclining posture. And you really ask patients, and they will definitely share with you, and you'll understand that 80% of Indian female adolescents, and even by and large women presenting to you with these problems, are having a sedentary lifestyle. We as doctors must be aware of what it actually means in the step counting is less than 5,000 steps per day. Typically, they tell us, "Main ghar ka sab kaam karti hu." But that is not enough, because we have to really identify that physically active means that she's taking at least more than or equal to 7,500 steps per day, and she's trying to meet the minimum physical activity levels that are necessary, and that is very important, and that can be a part of your history taking questionnaire. The differentials that you have to think of is, are androgens coming from any other sources like tumors? Are they exogenous through some medications? Is there a Cushingoid syndrome, NACAH, acromegaly, genetic defects in insulin action? Sometimes juvenile diabetes can be the primary presentation. Primary hypothalamic amenorrhea, primary ovarian failure, thyroid disorders, and prolactin disorders. Now let's look at these algorithms carefully. So if you have symptoms raising clinical suspicion for PCOS in an adolescent, hirsutism or treatment-resistant acne, irregular menstrual pattern, acanthosis nigricans, and central obesity, then hirsutism or moderate severe inflammatory acne, medications that cause hair growth, look at them whether they are having that. If the answer is yes, discontinue. If the hirsutism or acne persists, or if she is not taking any medications, do the biochemical testing for total testosterone, free testosterone if testosterone is normal, and hirsutism is moderate or severe, or if there is any other clinical evidence of hyperandrogenic endocrine disorder. Screen for non-hyperandrogenic causes of anovulation by HCG. She may be pregnant, chronic disease panel, FSH, LH, prolactin, TSH, and if especially associated abnormal menses exist. Now, if she has persistent abnormal menstrual pattern, and if she has obesity, acanthosis, and central obesity alone, evaluate for metabolic syndrome, look for dyslipidemia also in association, and insulin resistance, development of hirsutism, treatment resistance, acne, or menstrual abnormality. You have to do these biochemical testings. Now, if we have done this testing and she has anovulation, screen abnormal, and testosterone is normal, likely disorder other than PCOS, evaluate accordingly depending on the laboratory abnormality. If the testosterone or free testosterone elevated, then she has hyperandrogenemia, probable PCOS, laboratory evaluation to determine the cause of androgen excess. And if she is having all normal, if isolated hirsutism or acne like idiopathic, if isolated menstrual abnormality, likely physiological adolescent anovulation. If both hirsutism, acne, menstrual abnormality meets provisional criteria for diagnosis of PCOS in adolescents, and re-evaluate if hirsutism, acne progresses or if menstrual abnormality persists. So if you look at the entire gamut of things that you have to look into, these are the issues that we have to deal with whenever we are looking at PCOS. Now let's come to the treatment. The choice of therapy depends on the individual adolescents and the adult symptoms and her goals and preferences. Now, primary, symptomatic, and directed at the major clinical manifestations, which are abnormal uterine bleeding, cutaneous symptoms and signs, and obesity and insulin resistance. Now, typically, what would you call as abnormal uterine bleeding in adolescents, and that we must be able to differentiate, because they may be still, as I always say, is still a building under construction. So primary amenorrhea is when the lack of menarche by 15 years of age or by 3 years after the onset of breast development. Then secondary amenorrhea when more than 90 days without a menstrual period after previously menstruating. Oligomenorrhea is infrequent abnormal uterine bleeding, post-menarchal year 1, average cycle length is more than 90 days, fewer than 4 periods per year, post-menarchal year 2, more than 60 days, fewer than 6 periods per year, post-menarchal 3, more than 45 days, fewer than 8 periods per year. And this particular thing you can, of course, explain and ensure and assure them through this particular chart. And post-menarchal year 4 through perimenopause, average cycle length more than 38 days, fewer than 9 periods per year, only will be called as oligomenorrhea. Excessive uterine bleeding is menstrual bleeding that is more frequent than every 21 days or 19 days in post-menarchal year 1. Or prolonged lasts more than 7 days, or heavy soaking pads or tampons sufficiently to interfere with quality of life. So these are the things that you have to definitely identify and then only label them having abnormal uterine bleeding and work over them. Now, abnormal uterine bleeding, menstrual irregularity, excessive bleeding, or absence of menstruation, the first line of treatment is ordinarily estrogen-progesterone combination contraceptives, since these correct both menstrual abnormalities and hyperandrogenemia and ensure compliance. Now, typically, if they would have amenorrhea, the first line of treatment, if they are now in the 4th year post-menarche, you would first give them a progesterone challenge test. It's always a good practice to use a medroxyprogesterone acetate, which is supposed to be the most balanced progesterone, or the natural micronized progesterone can be used for the same purpose. And that can give us, the progesterone challenge test can give us an inkling as to what's actually going to happen and whether there is any problem. If they are positive for the test, then we know that they are not ovulating. If they are negative for the test, then we have to look for what's actually happening. And then maybe they are having a level, the top level kind of amenorrhea, which requires to be investigated. Now, if you are going to give her COCs, there are certain few things that one has to be aware of. First and foremost is you have to be sure to ensure compliance. Secondly, if the child is very young, I normally feel that teenagers, it's always better to use a progesterone pill only rather than giving them a combination estrogen pill, because we are definitely worried about their skeletal growth, a spurt being, sort of maybe tampered with giving her a combined pill. What you have to ask for definitely is these red flags. Does she abuse tobacco or smokes? Migraines, whether she has without aura, known high cholesterol or dyslipidemia, body mass index of 30 to 34.9, whether there is a family history of heart disease, stroke in the mother, father, or the brother. And plus, we have to also identify that it is important that the cycles are regularized, because chronic anovulation increases the risk of developing endometrial hyperplasia, which is associated with endometrial carcinoma. And therefore, it is essential that they are given some sort of a withdrawal bleed. And therefore, it's always a good practice to maybe give them 4 or 5 cycles in a year, or at least 6 cycles in a year, by giving them progestin withdrawal. And we all know that progestin is also present in COCs. It's a critical ingredient which inhibits endometrial proliferation and prevents hyperplasia that results from unopposed estrogen action. Now, while we are doing all this, we have to remember, again, in this building which is under construction, we have to consider their bone health. We have to ensure that they're taking proper diet, they have a proper exercise. Sarcopenia is something which has been given to understand today. There's a huge debility in the muscle mass, and that weakness is called as sarcopenia, and we have to start looking for it. Mental health issues, and whether they have any fear and anxiety factors which require to be spoken to them about. Now, as I mentioned, the first choice for me for very young adolescents who present with menstrual abnormalities or PCOS-like symptoms or signs, I prefer to give micronized progesterone, 100 to 200 milligram orally at bedtime, or medroxyprogesterone acetate, or depomedroxyprogesterone acetate can be given to them. And this can be used for 7 to 10 days out of each month or cycle, or maybe every 6 weeks. Many medications are there on the foray, like the drospirenone, the cyproterone acetate, the norethindrone, and the desogestrel. So when you decide to choose your combined oral contraceptive pill, it is always better to start off first with a levonorgestrel-based pill, for the simple reason that we are a little wary about these particular pills that have been mentioned, which may be containing very low estrogen sometimes, and they may also give risk to VTE. And also, it's been found that cyproterone acetate sometimes may cause hepatotoxicity, and therefore it's always better first to start with a baseline therapeutic pill, not the typical low dose pill. Start with a combination of a good estrogen and a progesterone pill, which is usually levonorgestrel. And then once your 2 or 3 cycles have set in, maybe you can shift them to giving any of the above low dose pills which have suited. There have been instances when proper histories have not been taken, that even young children have landed in issues similar to VTE. Adults who are sedentary, obese, who are just doing office-bound work are much at risk. So therefore, even in a younger child, it's always good practice to ask for a family history of VTE or any kind of venous or arterial stroke-like condition, and then decide what are you going to give them. Now, what are the additional advantages of COCs? They lower the serum free testosterone levels, mainly by decreasing the ovarian production via suppression of serum gonadotropin levels. The estrogen component increases serum SHBG levels. Modest lowering of DHES levels is found. Reducing androgen levels hinders the further transformation of vellus to terminal hairs, which occurs with androgen exposure. And in most patients with PCOS, treatment with COCs can be expected to arrest progression to hirsutism, reduce the need for shaving by approximately 1/2, and improves acne within 3 months. Now, excessive irregular menstrual bleeding due to ovulatory dysfunction is a common manifestation of PCOS and often is the initial presenting complaint. And especially in these young adolescents, it's a huge challenge because we have to differentiate whether they are having any underlying blood dyscrasia, which is causing this problem. And heavy uterine bleeding can cause anemia of a critical degree, and a vicious cycle would set in: anemia causing more bleeding, bleeding causing more anemia. And this is very typically seen in young girls, especially because there are many times it is iatrogenic because they are not taking their pills properly and on time. COCs or progesterone-only regimens are usually effective in managing this symptom. And levonorgestrel or therapeutic levels, as I mentioned, low-dose pills later on once you stabilize the entire cycle, and long-acting progestins can be another option wherein you have these slow-release formulations which can be given maybe once in 24 hours. So it's easy for the young child or the young woman to remember. Now, the another component of this PCOS is obesity, and we all know the negative effect of obesity on fertility was first noted 2,500 years ago by Hippocrates, and obesity is now known to be associated with menstrual irregularities, chronic anovulation, PCOS, and infertility. Everything in excess is definitely opposed to nature. And the central distribution of fat is more important than body weight in reducing fecundity. And we have to remember, especially in the Asian context, is the visceral obesity and the insulin resistance are key pathophysiological mechanisms behind PCOS. I always, when I interpret even the dyslipidemia, usually it's always a good practice to simply look at the triglycerides. And if they are found to be more than 100, I feel that is again dyslipidemia in the Asian context. 100 should be our cutoff point, and you must speak to women about this. Now, obesity, undernutrition, and all these abnormalities in the hormones, the PCOS, are definitely responsible for causing oxidative stress to reactive oxygen species, and they're responsible for a whole lot of complications during pregnancy and even for the general health of the woman. It's also associated with miscarriages, especially PCOS with obesity. And overweight and obesity have a positive relationship with the risk of spontaneous abortion in women who become pregnant after assisted reproductive technology treatments. Insulin stimulates androgen secretion, and together with androgens influence the pattern of body fat distribution in overweight women. And this also has to be borne in mind. And delayed or failed response to fertility treatments, including clomiphene citrate, gonadotropins, and assisted insemination, all aspects of infertility seem to be affected by PCOS and insulin resistance. So the British Fertility Society advises that fertility treatment should be deferred till the body mass index of less than 35 or BMI under 30 if they are below 37 years of age. Now, the moment we speak to our patients, I think they immediately go and choose another doctor. But all of us must maintain, because I have been at the receiving end of managing a lot of high-risk obstetrics, and believe me, obesity preconceptionally and excessive weight gain during pregnancy in women who are already programmed as PCOS is one of the biggest challenges and threats to women's life and health. Reproductive aging, as we all know, happens with age, but women who have PCOS and obesity, it's been found that there is a much faster aging of the ovarian function much earlier than would happen in a regular women. And especially Asian women, we have now much understood, are reaching and hitting menopause much earlier than their other global counterparts. So naturally, the much of our concentration also has to go on what do we do about this insulin resistance, because most of the data comes from the European continent and the American continent, and very, very less information is available from Indian women and Indian studies, for the simple reason probably we are very busy dealing with PCOD that we don't have time to write and sort of publish. So metformin, non-surgical weight loss measures and Myo-Inositol have been identified as certain such parallel paradigms of treatment. It has been suggested that even a modest loss of up to 5% of the initial body weight can result in spontaneous ovulation. I'm sure many of you must have observed this, that women just lose a little weight and just become pregnant and report to you with a positive pregnancy test. Luckily enough, if the same kind of milieu remains, they will continue with the pregnancy undeterred. But if not, they may land in a miscarriage, may land in an early onset preeclampsia or diabetes growth restriction and issues related to that. So body weight, if they lose and maintain it, restoration of the menstrual cycle regularity and pregnancy in obese women is found with PCOS. I find myself many a times speaking usually to my 100 kg on PCOS that please do not worry about the hormones. Your endometrial lining has become so thinned out that nothing is going to happen to it. You first lose weight. We will look about your periods later on. So 2% to 5% weight loss leads to 21% decline in free testosterone and resumption of regular ovulation. And long-term goal of 10 to 20% weight loss and waist circumference of less than 88 to 80 centimeters definitely gives rise to better outcomes. Weight loss resulted in significant reduction in blood glucose, insulin, androgen concentrations in obese, non-PCOS women, and more consistently in obese PCOS patients. And the raised production of SHBG induced by weight loss further reduced the circulating free androgen. Now, when we talk of physical exercise, it's not a good practice to just throw it on their face, because we now as obstetricians are also turning into lifestyle manager advocates. So for the first 15 minutes, you have to talk to them, and we also have to be aware of that if the patient tells you, main har roz 10 to 15 minutes chalti hu, that is only burning sugars and carbs. At 30 minutes, the fat burning zone starts. And then if you keep on pushing, you'll actually have your results of weight modification. So insufficient physical activity reasons why women with PCOS have a tendency towards overweight obesity, because exercise alone may not be helpful in weight loss. So 10,000 steps is equal to 30 minutes of daily exercise, or 15,000 needed for weight loss. And it has also to be compounded by proper nutritional guideline and diet modifications. And I always feel that the original Mediterranean diet is a better practice to have, wherein many trans fats and free carbohydrates or easy carbohydrates are cut off, and they are much more relying on complex carbs, proteins, and fibers in their diet. So it's important to lose weight and get pregnant, and you can see this in this beautiful cartoon. Now let's look at metformin. We all know that metformin has been identified as an insulin sensitizer, and today we are using it very, very effectively in gestational diabetes mellitus. And in GDM, it has been recommended by the government of India, and it has been found to be much more effective and much easy for us clinicians to use it in the place of insulin. And the concern, of course, was that if the patient is already taking metformin, is it going to cause any harm to the embryos? And the answers have been answered now with majority big studies that nothing of this happens. In fact, it's been found that if that metformin which you started before continued during pregnancy, helped in reducing the miscarriage rates phenomenally. So metformin reduces the insulin axis, but it also is known to have direct ovarian action. And this is somewhere it is also supposed to be important in attenuation of androgen excess and restoration of ovulation and improvement of fertility. And that has been observed in many studies. It also is a good practice to think of using metformin in women who are now finished their fertility, are in their adulthood, are polycystic ovarian syndromes, and it can be used to protect them from metabolic syndromes and also their endometriums from future endometrial cancers. Now, the therapy for PCOS is started with 500 milligrams daily, and it should be taken before the evening meal to minimize nausea, which is the cause of an approximate 15% of dropout rates. And the dose is gradually increased as tolerated to the effective dose of 1,000 to 2,000 milligrams per day. and the greater doses often may be better tolerated when divided into 2 daily dosages or when given in extended release form. It is contraindicated in patients with impaired hepatic or renal function, alcoholism, cardiopulmonary insufficiency, because it can cause lactic acidosis in these settings. And therefore, it's always a good practice to do a metabolic panel before you prescribe the metformin. The another kid on the block is the Myo-Inositol, and in certain studies it is found that the use of 2 into 2000 milligrams of Myo-Inositol along with folic acid per day is found to be a safe preconceptional medication, and it was known to effectively improve the symptoms and infertility for patients with PCOS. Because Myo-Inositol functions as an intracellular messenger in the mammalian oocytes, playing a role in the follicular milieu, meiotic resumption and oocyte maturation, and the use of 2 into 2000 milligrams Myo-Inositol plus 2 into 2000 micrograms of folic acid per day is a safe and promising tool in the effective improvement of symptoms and infertility for patients with PCOS. And I feel it is definitely going to be of good importance even for those adolescent girls where we are finding that these metabolic derangements are putting their ovaries under threat, and their weight loss is a challenge, where we can use Myo-Inositol much more effectively in that age group, and otherwise also as a sort of a adjunct to the various therapies that we are giving in PCOS. Now, what is Myo-Inositol? It's an isomerized and dephosphorylated precursor of glucose 6-phosphate and has been used more and more as a natural insulin sensitizer. The role of Myo-Inositol in the pathophysiology of PCOS has been the focus of recent studies, and it has been suggested that insulin resistance in PCOS women can be attributed to a deficiency of Myo-Inositol's intracellular metabolites, the DCI, and the IPG mediators of insulin action. It has been postulated that patients with PCOS have a higher urinary clearance of DCI, and in addition to its role in insulin sensitivity, it functions as an intracellular messenger in mammalian oocytes, playing a role in the follicular milieu, meiotic resumption, and oocyte maturation. So treating women with Myo-Inositol has been shown to reduce androgen levels, restore the ovarian function, lower the blood pressure, and decrease triglyceride levels. And it improves the endocrine parameters and insulin sensitivity, more so in women with higher fasting insulin levels, which are defined by a fasting insulin level of greater than 12 microunits per ml. And although weight loss and dietary interventions are also known to improve insulin sensitivity and hyperandrogenism and restore ovulation in women with PCOS, studies investigating the potentially additive benefit of combining lifestyle intervention with Myo-Inositol would be beneficial, and all of us should actually encourage such studies and invest into them. Myo-Inositol is a safe and effective natural medicine for improving insulin resistance, and it should be recommended in conjunction with other positive lifestyle modifications for the management of PCOS and insulin resistance. Now, the question comes, if the patient is coming to us with fertility desire, how do we deal with them? Now, clomiphene cited through 2 multicenter concurrent trials in overweight and obese women with PCOS and anovulatory infertility reported higher ovulatory and live birth rates with pre-treatment lifestyle modification and weight loss when compared with immediate treatment with clomiphene citrate. And this is very important, because if you're going to get them through fertility treatments, it is important that their health is optimized before they embark on pregnancy. Many times I tell my patients, the nature has gone in denial of a pregnancy, probably to protect you. So till the time you become healthy, it is better that we try to protect you and first become healthy and then plan a baby. Now, the treatment of hyperandrogenism versus insulin resistance in infertile polycystic ovarian syndrome, the OWL PCOS, an open label study of overweight or obese women with PCOS and anovulatory infertility, assigned to 16 weeks of pre-treatment with continuous COCs, lifestyle modification, including caloric restriction, anti-obesity medications, behavioral medications, and exercise, or combination of both, followed by up to 4 cycles of clomiphene citrate for ovulation induction, was done in this study. While there was another study, the PPCOS2 trial, a double-blinded trial of up to 5 cycles of clomiphene or letrozole. And what was the observation in the PPCOS after 4 cycles of clomiphene with no pre-treatment? The cumulative per cycle ovulatory 45% live birth rates, 10.2% out of 2 227 of 619 cycles and 19 of 187 patients. While in the all PCOS, a 16-week pre-treatment lifestyle intervention resulted in an approximate 6.5% weight loss from baseline improvements in ovulatory cycles, 62 to 25%, live birth rates 80 to 129 cycles in 12 to 48 patients, and pre-treatment with COCs alone or combined with lifestyle intervention did not affect the outcomes. So what is important is lifestyle change and pre-treatment therapies. It is also found that with your treatments, there is definitely an alteration in the ovarian morphology where there is rise in SHB and a reduction in free androgens and improved insulin sensitivity. Decrease in the volume might be due to the reduction in the microfollicles and ovarian stroma. Amount of ovarian stroma is correlated with overproduction of theca-derived steroids, particularly androstenedione. Long-term pharmacological inhibition of ovarian function in patients under COCs treatment shows improvement. And therefore, if you look at a summary of multi-step approach to treatment of anovulatory infertility associated with PCOS, because these women are at much increased risk of hyperstimulation and multiple pregnancies, which we are definitely concerned about. The first line would be weight loss for high body mass index. The cost is low, multiple pregnancy risk is not increased. First line is letrozole, alternative can be clomiphene citrate. Second line is follicle stimulating hormone injections. And high includes high order multiples, and you have to be careful. Maybe this can be accomplished by doing frozen embryo transfers and after that, so that helps in reducing the complications related to OHSS. Second line is ovarian drilling. Again, the cost is high and multiple pregnancy risk is not increased. And third line would be in vitro fertilization, very high cost, but high but reducible with single embryo transfers or frozen embryo transfers. Now, laparoscopic ovarian drilling is found to be a surgical approach, and it is known to help by reducing the ovarian secretion of androgens and proteins, resulting in an increase in LH and FSH secretion. Ovary becomes more responsive to stimulation by endogenous gonadotropins. Ovulatory cycles occur in approximately 80% of patients with a range of 30 to 90%, and normalization of ovulatory function continued for many years in the majority of patients following ovarian drilling is important. What I want to draw your attention to is important that it is always considered as a second line or a third line treatment after everything else has been tried, because there's always a concern that there can be an injury or a damage to the ovary, and it may be deprived of healthy follicles which are present there, and that has to be, therefore there has to be a very proper selection of these patients. The normalization of ovulatory function continued for many years in the majority of patients following ovarian drilling. Now, it has been practiced for decades, but unfortunately, the technique has not been standardized regarding the energy source. So, number of punctures, dose, and duration per puncture. Based on limited dose ranging studies, 3 to 6 punctures per ovary at 40 wattage of coagulating modulated, that is mixed current, for 4 seconds per puncture seems reasonable. Traditionally, this is an ovarian drilling, but some workers also have attempted doing the transvaginal hydrolaparoscopy, which is found to be less traumatic and includes avoiding vascular injuries and other injuries. Unfortunately, some of you may be having such experiences, but I have no experience of doing this. Polycystic ovarian syndrome also means that we have to prepare, communicate, overcome, and support our patients at every juncture and talk to them and try to help them. Now, what is the role of a bariatric surgery? While we're talking of surgery in obese women, weight loss after gastroplasty quickly restores normal insulin secretion, clearance, and action on glucose metabolism, and is found to be the most durable and effective treatment for morbid obesity, with the safety of laparoscopic approach and improved understanding of metabolic changes occurring in bariatric patients post-operatively. Morbidly obese women with infertility secondary to PCOS have restored bariatric surgery. And there are a few patients and now which we are dealing with post-bariatric surgery. They come with conception. Sometimes they require a little bit of assistance and then become pregnant. And there are various types of such bariatric surgeries which can be performed. The commonest ones performed today for these patients are the vertical sleeve gastrectomy, which is found to be, wherein the stomach is closed down and that's supposed to be. Now, does it have any scope? It is very difficult because there are not much large studies, but sometimes you find that the patient's age is growing, and such a patient who is having an age which is growing, or we are concerned about her ovulatory function and the time is less, we cannot suggest weight loss for more than 3 months, max to max 6 months. And therefore, in such a situation, maybe these can be considered, but then they are expensive, they're associated with issues. Now, women are now more aware of diminishing fertility with age, and they still significantly overestimate female fertility potential beyond 35 years of age. What we have to also understand is, while you are concentrating on your PCOS patients, also look at your partner parallelly, because many times even males are suffering from obesity-related issues or high insulin resistance, which is causing probably infertility contributed even from the male. Now, both non-surgical and surgical weight loss can improve fertility, and this was illustrated in a series in which 15 of 32 women who were unsuccessful in their attempts to conceive prior to bariatric surgery became pregnant following surgery. And there is a rapid return to fertility who conceived following bariatric surgery had fertility rates of 15 to 44%, and return to fertility can be rapid, as all of 24 oligomenoric women in one series resumed normal menstrual cycle after a mean of 3.5 plus minus 2.1 months post-operatively. When to plan a pregnancy is a question, and usually the bariatric surgeons say that the women should avoid conception for first 12 to 18 months after bariatric surgery, but I have at least 2-3 patients who have conceived within 6 months. And then, of course, with all the various things that we have to look into them, because it is important to delay, because they may be, first and foremost, we must give them an opportunity to optimize their weight loss, and plus there may be associated nutritional deficiencies surgically induced which require to be treated. Any woman who is embarking on a pregnancy with PCOS or obesity, we have to remember their metabolic parameters, the gastrointestinal symptoms, nutrition, assessment of anemia and deficiencies, vaccinations, and type of bariatric surgery, of type of treatments that she has taken. Prenatal surveillance should be done for diabetes, weight management, nutritional assessment, and birth planning throughout the entire pregnancy, because PCOS women definitely are risk factors for preeclampsia and diabetes. So the need of the hour is careful assessment of fertility potential throughout, practical call on lifestyle modification and its timelines. The male obesity factor has to be accounted for. Comparative studies with non-surgical and surgical approaches. PCOS less BMI to be evaluated, and developing a nexus between bariatric surgeons, OBGYN physicians, nutritionists is important. There are some more things here which you can read if you want to about bariatric surgery. In conclusion, correct diagnosis, risk assessment stratification, weight loss is the mainstay, fertility issues and potential and future disorders have to be looked into, and we must individualize our patient care and consider the options as metformin, Myo-Inositol, structured programs, and bariatric surgery. So it's important that all of us join hands and fight polycystic ovarian syndrome, because it is the future programming of our society which is important. And especially when we sit as obstetricians in our clinics, we are responsible for the healthy future society creation through healthy nation building. Thank you for a patient hearing. And this is me. I'm here because I love to share knowledge, and you can contact me on these contact numbers. Thank you so much. Over to you, Mr. Balaji.
Ma'am, this is Dr. Kiran from Shield Healthcare. Ma'am, thank you so much. I think it was a very lucid, albeit comprehensive talk. So already there are a lot of questions, ma'am. I'll just read the questions out to you with your permission, ma'am.
Yes.
Ma'am, the first question is from Dr. Meenakshi.
Yeah.
What is the dose and duration of metformin used in adolescents?
So as I mentioned, you must start with a 500 milligram. The ideal dosage is about 1500 to 2000 milligrams on an average per day. Given in 3 divided dosage is a good idea. But you should start with a 500 milligram dose. Many times there are tolerance issues. After 7 days, you can give them a slow release formulation. So this slow release formulation, which are about with a strength of 850 or 1000 milligrams, are ones you can just take them maybe twice in a day or once in a day. And they also ensure better compliance and better tolerance. And additionally, if not before food, you can ask them to take it along with food. Even that is known to help compliance better. But you should also remember that some of them may have gastrocolitis or loose motions, and you may have to help them by giving additional probiotics or changing their dietary practices. That would help.
Thank you, ma'am. Ma'am, I think Dr. Hidinath Lad wants to ask a question. Sir, you're unmuted. You can ask.
Yes. Hello.
Dr. Hidinath? Maybe not audible, ma'am. Okay, I'll move on to the next question, ma'am. Ma'am, Dr. Swati wants to know your comments and on especially if you can just summarize the role of Myo-Inositol once again.
Yeah. As I mentioned that insulin resistance is something that we require to define in the Asian context. And we find that Myo-Inositol is present in the nature also in many of the sources, nutritional sources. Unfortunately, we seem to be deprived from these sources because of various reasons, their availability or maybe our digestive capacity, and then the adequate amount that requires to be consumed. So when it is given in this particular formulation, it is not only important to reduce the triglycerides and the insulin resistance, but it is also known to improvise the ovarian health by probably, I feel this is because of the reduction in the oxidative stress. That is what most of the studies say. Now, Myo-Inositol, if you look at it, it is also being recommended in certain conditions like Alzheimer's disease, wherein it has been found to give, deliver oxygen intracellularly. So many small studies are coming up with this. Unfortunately, we require to have larger studies which will be able to help us to address this issue. Yeah.
Thank you, ma'am.
Answers your question. Yeah.
Yes, ma'am. Thank you, ma'am. Ma'am, there is a comment from Dr. Divya. Excellent presentation, ma'am.
Thank you so much. My friend Santosh Kirloskar is asking me micronutrients, vitamin D. Yes, you have to look for nutritional deficiencies, Santosh, and give them to your patients because they are suffering from problems.
Thank you, ma'am. The next question is from Dr. Shireen Parveen.
Yeah.
When you have a 21-year-old lean patient getting only withdrawal bleeding, the role of ultrasound in PCOS in this situation.
Okay. So now, first of all, just find out why she is excessively lean. We have to find out what is the reason. Is she having any other kind of issues? She is having anorexia. Is she having behavioral disorders? What are the problems? Because at 21 years, and what is her lifestyle? That is important. Then, if she is not looking forwards to a conception, it is important that she just gets a withdrawal bleed and that's it. Once, when she's trying to get into a fertility treatment, you can evaluate her further because it's important that you do not allow her ovaries get into continuous mal exposure to the gonadotropins and get into morphological enlargement in size. So till that time, you have to just protect her general metabolic health, her ovaries, and things. But identify whether she has the top level, the hypothalamic pituitary abnormality, which is giving her amenorrhea. That can be one of the reasons. Very rarely you can have premature ovarian failure. I've had one of my own colleagues, a junior colleague, who actually was a POF, which was not diagnosed primarily. And she was being treated as PCOS. And therefore, we have to look at all these things. Sometimes just doing the FSH-LH levels can give you an insight whether they are actually POFs.
Thank you, ma'am. Ma'am, I think this Dr. Swati is asking a question in continuation to her Myo-Inositol question.
Yeah.
How long can we use Myo-Inositol, ma'am?
You can use it anywhere between 1 to 2 years. But always remember that don't leave your patients away. Your PCOS patients are your regular patients. They have to, you can treat them as special patients. You can treat them as a special OPD for that matter. And you have to give them maybe return or whichever way material as to they have to change their lifestyle. Every time you must to your lifestyle. That's not helpful.
Thank you, ma'am. Ma'am, the next question is
usually well, we have found results in a period of about 6 months. From
Dr. Shilpa Raut, what are the investigations we are supposed to do to diagnose PCOS patients?
I think I mentioned the list of investigations in the algorithm that we talked of. Yes. Now, if the PCOS patient, it depends on which PCOS are you looking for. Especially if the PCOS is going in for a fertility treatment, then in that case, you will be doing her gonadotropin levels, prolactin, hypothyroidism, micronutrient levels. You'll also look for insulin resistance, fasting insulin, maybe glycosylated hemoglobin. You should also look for AMH. It's always better, but that gives you a baseline as to where you are heading, because sometimes because of very high volume of, and baseline fertility scan is very important to look at the ovarian volume, because if that is going to be abnormal, that gives you a baseline thing from where you have to start working. Do their metabolic screen, because they are going to embark on pregnancy, which is going to be a metabolic challenge. Now, if you have a younger adolescent, then you can much depend on their clinical signs and symptoms and the menstrual cycle. And generally, there's no need to put them through actual investigations if they are responding to your treatments. But if a patient of infertility is going to be there, you should be careful, because you're not only going to make her pregnant, you have to see that she sells through that pregnancy without any complications.
Thank you, ma'am. The next question is from Dr. Prajakta. The case situation, ma'am. You have a 12-year-old adolescent with menorrhagia or continuous bleeding.
Yeah.
What is the line of management, and what is your opinion about OC pills in this situation?
12 years adolescent, I would rather treat them either by progesterone primarily, because mostly it's anovulatory. But first, definitely rule out whether she is anemic, hypothyroid, and whether she has a exposure to tuberculosis. We are in India. We have to look for this. Look for blood dyscrasias. Sometimes it's always a good practice to just look properly at their complete blood count, and that would give you an insight. And once your anemia and everything has been checked, and if she's still continuing to bleed, you can use her hemostats and high dose of progesterone. The best progesterone used can be the medroxyprogesterone acetate, as I mentioned, or you can even use the slow release formulation of the norethindrone. And then if they just don't respond to your progesterone, then you may consider giving them an estrogen, because sometimes estrogen is necessary to make the endometrium sensitive to progesterone. But then rather than giving a combined pill, it is better to give her estrogen first, a pure estrogen, and then you supplement it with progesterone in the later part. That's usually what I practice. Usually they respond. Now nothing responds, then you may have to shift to a combined pill for a short period of time till you're building up their hemoglobin and everything, and then they should respond.
Thank you, ma'am. Ma'am, again, this question also is a case situation from Dr. Bhavi.
Yeah.
You have a 35-year-old PCOS patient who's completed her family and has a BMI of 27.
Yeah.
How do you manage the oligomenorrhea here, ma'am?
Okay, so if she has oligomenorrhea which is bothering her, then it's always better just to give her on from every 16th day of the cycle, from the 16th day onwards for 5 days, she can take the progesterone supplement. So that it keeps her endometrium protected, she gets a cycle and she's happy. And look for insulin resistance. She may be having a sedentary lifestyle. You have to change that, because now she is just 27 BMI is a borderline BMI. If she doesn't take care, on the wrong side of 35, women tend to put on weight. So therefore, we have to have a concept of not only the skeletal system becoming stronger, because she's gradually going to go into menopause, but her muscle foundation also has to be laid down well. So these things have to be spoken to the patient. And many patients they are much happier not even having their menses. Then in that case, you can consider giving her an LNG IUS, but you said that she had oligomenorrhea, so that seems to be a concern that she wants to have a periods, then it's better to give her progesterone withdrawal. That's quite safe. And this can be given for 2 to 3 years.
Thank you, ma'am. The next question is from Dr. Hema. How does one decide on putting a patient on either Myo-Inositol or Metformin according to age groups or BMI or patients wanting fertility?
No, there are no such guidelines for age group wise or anything. Any presence of insulin resistance, any signs of insulin resistance, you can put them up on any of these insulin sensitizers. Now, if the patient has definitely a very high glycosylated hemoglobin, or she has fasting sugars which are abnormal or sugars which are abnormal, metformin necessarily has to be a mainstay. But Myo-Inositol is something which I always choose to use despite all this. Wherever there's insulin resistance, you will find that my prescriptions always are supplemented with this, even during pregnancy. Because I feel then the need of the dosage of metformin reduces, their other therapies become more effective, and their possibilities of conception definitely increase.
Thank you so much, ma'am. The next question is from Dr. Shakuntala. Are there any studies of Ayurvedic medicine in PCOS?
Yeah, I must share something with you. This is what happened with our Department of Pharmacology in Bharati Vidyapeeth. And we decided to have this study. And we gave these patients a concentration of turmeric and amla. And these were given to girls who were severe PCOD. It was a double-blind study. Along with all the treatments, some were given this and the others were not given. And some of them, this was just a very small study done on about 52 patients. Part of them also were undergoing infertility treatments. And we found that the ones who took these supplements had better cycle regularization and better ovulations. So lifestyle change definitely is something which we are hugely underrating. Women have a lot of anxiety. You will not believe the moment you see the pregnancy test comes positive, the next thing that the woman says, I am having a backache. Now, I have still not understood the pathophysiology of 4 weeks pregnancy causing backache. So you can understand the amount of anxiety women are having today. So that definitely gives rise to such kind of hormonal abnormalities, giving rise to PCOS like conditions and metabolic disorders. Hormonal abnormalities are very common because of these.
Thank you, ma'am. That was very interesting.
Yes.
Thanks for sharing that.
Yeah. I'm going to become a lifestyle consultant.
Thank you, ma'am. Ma'am, I had one question from my side, just for curiosity. We advocate so much about exercise and lifestyle as first time.
Yeah.
There are a lot of papers showing the immense benefit of having an excellent lifestyle and exercise.
Yeah.
How practical it is in terms of counseling for patients, and what are the practical difficulties you face, ma'am, or clinicians face generally?
Yeah, the observation that I face is first and foremost when I actually do their, analysis. I use certain questions to analyze exactly what kind of lifestyle they are having. And I put forth in front of them the Government of India guidelines, what it mentions, why your BMI has to be this, what is that, and what are your exercise patterns. So if you categorically analyze their nutrition and their exercise physical activity pattern, a lot of clues you get from them. The third component is their dietary recall. While they're sitting in the OPD, I make them write their diet for the last 48 hours. And that gives me an insight as to what they're really eating. So the moment you get that, and if you decide to change them without reprimanding them, guiding them, tell them that, okay, these are the changes that you make till your blood tests come in, then I'm going to give you certain supplements. Then we can consider giving them metformin, then maybe thyroid supplement, hypothyroidism, kalia treatments, or your myo-inositols, micronutrients. And then they gain this confidence that something is happening. You have to constantly keep a linkage with your patient and keep on hand-holding them periodically. You have to also talk about what is their mental makeup and how they are going to be responding to that. So in my practice and with my counseling, I've observed that 90% of the patients respond to this kind of an approach. 10% are extremely resistant. First of all, they are not having maybe access to the treatment because of various issues, or some of them just don't want to listen, or they find it difficult. There are some patients who are actually finding it difficult. I must be having lots of patients at this point who are weighing between 90 to 120 kgs. And they are the biggest challenge. For them, you have to keep on talking to them and guiding them. But then they are resistant. But I'm seeing that even if they lose about 6 to 7% of their weight, they start ovulating and become pregnant. And that's a surprise. You'll not believe, yesterday, my previously PCOS patient whom I had such a difficulty getting her pregnant, she delivered 1.5 years back. She called me up saying, Doc, my UPT has come positive. I don't want to have this baby so early. I'm coming for abortion treatment. And yesterday I said, you come up first, let's get your scan done and let me check you first. Sonography, she directly went for scan, didn't come to me, had done a blood test, 30 weeks pregnancy. So it's just by losing weight, she conceived this time naturally.
Absolutely, ma'am. Thank you, ma'am. Ma'am, the next question is from Dr. Sumita Lakshmi. Again, a case scenario, ma'am, for you. You have a 20-year-old thin PCO patient who presented with multiple follicles with CC, irregular cycles.
Yeah.
What is the management, ma'am?
Multiple cycle failures. Now, have we done her ovarian volume? Kitna hai uska?
That's not specified here, ma'am. This
Because
multiple.
I will tell you, I don't know, I can just tell her one thing. See, sometimes, some patients also present with severe ovulation pain. I have a patient who was a dancer, but she used to have still a central obesity. She had a wonderful lifestyle, but she was extremely anxious. These were the only two things. Investigation found her insulin resistance was high and her ovaries were always increased in volume. When we put her on hormones for a period, the ovarian size reduced and then we started on ovulation treatment. Like this, she did not respond to clomiphene cycle. I decided to do her AMH and we found that the AMH was phenomenally high. And therefore, I finally said, let's shift to the second line of treatment and let's do your ovarian drilling. Ovarian drilling, I found that her ovaries were extremely tense and stretched. We just did the typical classical, what I described, ovarian drilling. And then after 2 months, she started ovulating. But then I stimulated this time with letrozole and she did conceive and she's carried that baby to term. She had a little bit of GDM kind of a thing during her pregnancy and otherwise she's done well. So you have to keep on individualizing your treatments. Maybe it's a very resistant ovary and you have to look into whether she requires a surgical approach or maybe a longer progesterone treatment, because I know now currently a lot of ovulation pe talk ho gaya hai. Dr. Jatin Shah, I always listen to his talks and he mentions that before then planning ovulation induction, it's always better to start on giving a progesterone cycles for 2 months or so and then start ovulation stimulation. That can also be a better approach. And use letrozole instead of clomiphene citrate and combine that also with Myo-Inositol and Metformin for better results.
Ma'am, there was one clarification. The ovarian volume in this case was 30 cc.
30 cc is बहुत ज़्यादा. 30 cc is too much, na? So we require to look at her AMH, whether it is very low, because very low AMH, she can have problems to her follicles. So, and if the AMH is very high, then maybe you will be justified in doing her ovarian drilling.
Thank you, ma'am. Ma'am, the next question is, when adding D-chironositol to Myo-Inositol, what is your view on that?
I didn't understand you. I mentioned
yes, ma'am. So I think they were asking when D-chironositol is added to Myo-Inositol, what is your view? I think you mentioned that in your presentation.
See, basically, now you have to understand that whatever has been found to be the best source is a combination. That study which I mentioned is talking about giving 2000 milligrams, that is 2 grams twice daily, 4 grams. And therefore, because it has to be pharmacologically and pharmacokinetically properly available. So you have to choose your Myo-Inositol properly.
Thank you, ma'am. Ma'am, the next question is from Dr. Preeti. What to tell patients to avoid among the common food that we eat when we have PCOS?
Okay, the commonest things that we avoid to ask them is trans fats, then refined foods, especially the pickled storage foods, high salt diets. All these are important. What is very important is the balancing the diet. Balancing the diet means that you have to take very high quantities of protein and fibers to the tune of 200 grams per day. Proteins approximately 1 gram per kg body weight. They have to take a lot of probiotics in their diet. And they have to ensure that they are taking balanced diet every time. Like every food, every serving has to have all these components in that. So many times if you look at our typical Indian diet, it is much more carb based. We require to balance it with proteins and probiotics to make it better, palatable, and giving better results as far as weight loss is concerned. We can have a separate session on nutrition, by the way.
Sorry, definitely. That's a very vast subject in itself. Thank you, ma'am. Ma'am, there's a question from Dr. Sanjana. How do you differentiate PCOS and premature ovarian failure?
Do FSH levels now. If the FSH levels have come more than 20, then it is premature ovarian failure on the cycle day 2 or 3 of the cycle. Repeat it again and see. Usually it's said FSH more than 40 is a menopausal level.
Thank you, ma'am. Ma'am, the next question is, what is the role of orlistat in patients who are not responding to lifestyle?
Yeah, it would act similar to some sort of a bariatric surgery. They are not responding to lifestyle. I know the typical thing that I tell them, that you are a young woman, your muscles require to push it more. Okay, so that 4,000 steps which the European society has talked about walking to reduce the insulin resistance, here we should tell them that you require 15,000 steps. So failed lifestyle management means actually what also requires to be investigated.
Thank you, ma'am. Ma'am, when you have a post-menopausal PCOS women, what advice would you give them?
With the they have to be screened for metabolic abnormalities and endometrial cancers. They are at risk of these things. Ovarian cancers also nowadays. So we have to be looking at them. They have to come for regular screens. They have to have a healthy lifestyle. Just because you stop having children, that doesn't mean that you should not maintain your bone mass and your exercise and your brain mass and your brain health and your mind health. All these things matter. So they have to come for regular scans. It's always a good practice to call them for a transvaginal scan once in a year and look at their metabolic screening for hyperlipidemia, diabetes, breast examination. These are mandatory like any other menopausal woman. I think all of us should undergo this, because I feel that all the problems that we have in our country are because of abnormal insulin resistance, either triggered by the environment, your stress, or your inability to do exercise, or your dietary abnormalities.
Ma'am, a couple of questions, if it's okay. A couple of more questions.
Yeah.
Okay, ma'am. Ma'am, the next question is from Dr. Sumita Lakshmi. She says, ma'am, you were talking about progesterone before or prior to ovulation induction. In this perspective, when to use OC pills prior to ovulation induction and how to individualize them?
See, if the patient's having a very irregular cycle, and if the ovarian volume is very high, it is always better to put them on a combined oral contraceptive pill for a 3-cycle phase. Once that has been done, go back and check her metabolic and gonadotropin parameters. And then now is the time when everything is optimized, you can consider taking her for ovulation induction. So you can use that 130 days interim period where you'll be starting her on pre-conceptional micronutrients, maybe the calcium, vitamin D, along with folic acid, B12, DHA can also be added to that. You can then start her on progesterone in that cycle. And then when she gets a withdrawal bleed, give her ovulation induction.
Thank you, ma'am. Ma'am, you mentioned probiotics. So, Dr. Geetanjali asks...
Our famous curds, dahi, chas. India is full of that.
Absolutely. I think you answered the question very beautifully. Okay, ma'am. Ma'am, one more question before we go. From Dr. Sanjana Mahesh. Medications for Alzheimer's disease in post-menopausal women.
Unfortunately, Sanjana, I would also want to know, yaar. We really don't know, because most of the people with whom I've spoken, because my own father is suffering from Alzheimer's, so naturally I'm doing a lot of work on that and trying to find out things. But what they're saying is that it is important that we keep on having a complex thinking pattern and reduce our multitasking, have proper nutrition. Because now a weight loss ke jhamele mein, sometimes we become hypoglycemic, and that hypoglycemia is not a good thing for your brain. You need to eat good brain food. That's what I understand. Keep on doing complex things. Like previously women used to say that mantra, jap, keep calm. Maybe that would help. But then unfortunately, I am not aware of what medicines can be given. And my very dear psychiatric friend tells me that it is a disorder. It's a lifestyle disorder. If you're not going to die of a road traffic accident or cancer, you will probably suffer from Alzheimer's.
So, ma'am, thank you. A big thanks from Shield Healthcare. A personal thanks from me, ma'am. I think your talk is very lucid and at the same time very comprehensive and very practical. And I'm sure the audience still have a lot of questions which I will take and mail across to you, ma'am.
Certainly, with pleasure I will answer them. Yeah.
Sorry, ma'am. And thank you so much for sparing your time for this talk, ma'am. I think it was a very, very, very nice session. And there are lots of compliments, ma'am. Excellent session. Fantastic session. Very informative. And thank you so much once again for all the audience also for logging in. And we hope to have more sessions with ma'am in the coming days.
Thank you.
Thank you so much, ma'am. Thank you once again.
God bless you. Bye-bye.
Thank you very much, doctor.
Thank you. Bye, Mr. Balaji.